Sakib, thank you so much. That was a wonderful talk, really educational and excellent for all of us. Hossam, are you still live over in Abu Dhabi?
Yes, we're here. Do we have any speakers? Do we have?
So
Dr.
no, I
Usman
think we
in the
move
audience?
on next to your talk about the team approach to vascular disease.
So we have two talks. We'll go back to Dr. Khawaja Hassan. He's going to present us with a limb salvage case, and after that, we're going to wrap up with a multidisciplinary approach for limb salvage.
Fantastic. That sounds great.
Good morning. So I'll be presenting the case with regards to limb salvage. So 49-year-old gentleman, prior history of hypertension, dyslipidemia, uncontrolled type 2 diabetes mellitus despite being on insulin with an HbA1c of 8, history of deep venous thrombosis, history of peripheral artery disease, was admitted to the hospital with fever and bilateral lower limb pain with non-healing ulcers on the feet bilaterally. On examination, the patient had bilateral non-healing ulcers with no palpable pulses. So these were the wounds on the foot. So ankle breaker index was 1.12 on the right side, 0.99 on the left side. However, the toe breaker index was significantly reduced bilaterally. The CT angiogram showed severe stenosis on the right side of the distal popliteal artery. The anterior tibial artery was occluded proximally. The peroneal artery was diminutive. And the posterior tibial had severe stenosis proximally as well. On the left, the anterior tibial had focal severe scattered stenosis. The peroneal artery was diminutive and terminated in the mid-calf. The posterior tibial was diminutive with severe focal stenosis. You can see the image right there. So we proceeded with the angiogram, and as you can see, the common femoral artery is patent. Over here, you can see that the anterior tibial is occluded proximally. There is serial stenosis in the posterior tibial artery. And when you go to the foot, the anterior tibial reconstitutes probably in the middle. So what would be the next step in the management of this patient?
So what would you guys do in this situation?
I think, Hossam, let's pick on some of our panel members here. Sakib, do you want to, you're predominantly venous, but you also deal with arterial disease. The angiogram. Yusuf, can you go back to the angiogram again, please?
Yes.
So I think the below knee one is the key because you have good flow up until the popliteal. And then below that, essentially, you don't have a whole lot going on. You've got serial occlusions in the posterior tibial, and the anterior tibial looks like it's fairly well totally occluded.
This is the runoff. Approximately everything's okay, and the PT goes into the foot.
Can you hear me? sorry, I missed a little bit of initial presentation, but as I remember, you had.
Sorry, we can't hear you.
Can you hear me now?
Yes.
Yeah.
Okay. So the patient has an ulcer on great toe, and the key of peripheral arterial disease treatment is you have to keep the flow in line, starting from the iliac artery all the way down towards that area where the ulcer is present. So there are different ways of doing it. Number one, you want to make sure that there's no inflow disease. So you have to treat inflow disease first, and then open the flow all the way down. If we are not sure which perisome is that area supplying, you have to put methylene blue to see which artery is basically involved and open that artery. So opening means you can put a balloon. Drug-coated balloons have great results. I know there's studies going on nowadays saying that there's increased mortality, but new studies have shown that that is actually not true. So drug-coated balloons below the knee is difficult because all sizes are not available. And you can use in a TP trunk, and you can use in the femoral arteries. But going below the knee, you have to balloon, and drug-coated stents have a great results also in below the knee procedure, especially if it's around or above the ankle area. Around the ankle area, I've never actually, other than once for the limb salvage, we don't like to use the stents, drug-coated stents in that area. But ballooning and supplying the blood to that area will improve the ulcer healing process.
Thank you. Those are very valid comments, excellent ideas. We also have another peripheral vascular interventionalist amongst us. I'll pick on you as well. Let's see if you have some ideas. Dr. Amber is from Lahore. She runs a cath lab and has a deep interest in vascular interventions.
I think we have some limited experience on this, and below knee is difficult for us. But we would again, as Dr. Said mentioned here, that we would like to have a continuous flow, if possible, right down to the toe that you want to heal. And we do an ipsilateral antegrade approach. We have little in terms of equipment. So here, if we can get up to the pop and then wire what we can, which looks like a posterior tibial artery, and just balloon whatever we can. We have limited equipment, so most of the time we use coronary equipment. And I have actually never stented below knee, except for somewhere in the proximal bifurcation sometimes, when you can use a small drug-eluting coronary stent, which we have used. We sometimes end up having some long balloons like 2.5 or 3. So we just use them on low-pressure inflations and rebuild the posterior tibial artery, which looks like that we can do that. For the anterior tibial, I'm not sure if we can probe it and get through. So that's my...
Thank you. Thank you so much. Would you like to have any comments?
I think I agree with all the comments. Again, we have very limited experience with peripheral interventions. I would have been interested to see the distal outflow at the level of the ankle to see if how the supply in the foot is. But I think the peroneal is diseased as well. So probably opening up whatever is possible below the knee to establish as much flow as we can to the wound. So maybe peroneal and posterior tibial both need a little bit of work done. So we have some peripheral sport catheters, and we've got the 014 wires. So I think something like a Rubicon and a 014 wire would probably do the trick, and then rest is the drug-coated balloon if possible.
We have support catheters, and we use something like we have a Prograde or any other fine glide gas that we can use. And I tend to use a coronary wire, something like a Miracle wire, and which is hard and sharp, and it can get through a 300. We use about a long wire like 260 centimeter or something, and just make our way into the arteries.
Thank you. Any vascular surgeons in the room that would like to take on this patient from a surgical perspective? You're interventional radiologist? Okay. So Hossam, you heard the comments from here. Was that all very clear? And then there was a question about interventional radiology. The question is that how comfortable and how far can interventional radiologists push their skill levels to treat this kind of disease? So I think maybe if you could, we could get a couple of comments from yourself and Andrew Rivard, and then we can see what you did with this patient. Interventional radiology, Andrew. Do you think that?
Yes, there's overlap in specialties in the treatment, in the vascular treatment of peripheral arterial disease. Any specialty who have the right skill set can perform these interventions. They need definitely the appropriate training and the experience, because these small vessels, they need talent to select them and treat them, and at the same time not to burn bridges into open intervention if needed. That being said, yes, this can be performed by interventional cardiology, interventional radiology, or vascular surgeons that trained in the vascular area.
I think we are running a little short on time because we have another speaker as well.
Yeah.
So why don't we see what was done with the patient so that we can get a closure on this case?
So we proceeded with orbital atherectomy.
Wire was used. Do you know, was that an 014 wire with a support catheter?
Yeah, so I don't really recall.
So I can
but
comment on this because I think this was a patient that was done by myself. So we used an 014 coronary wire, a regular wire. Usually you want a more slippery wire which will not damage the vessel too much. I think that a lot of this depends on how well you can see the distal vessel or not. I think someone had raised that question, and so that's very important. Our philosophy in general, Hossam and Francesco, correct me if you think I'm wrong, is not to implant stents below the knee. That is always the effort, unless we are absolutely pushed into a corner and don't have any bailout strategy. It's kind of the final bailout strategy, and we have seen some disasters with coronary stents, although in general the studies show that they work, but these are very small patient numbers, and I don't think that I would condone the policy of generally stenting below the knee. So we were able to cross with an 014 wire. We picked orbital atherectomy